Welcome to my presentation called Motives for Cannabis Use in Individuals with Clinical Anxiety. Before we get started, I'd like to acknowledge my affiliations for this project that I'll be presenting today, McMaster University and St. Joseph's Healthcare Hamilton, specifically the Anxiety Treatment and Research Clinic. I'd like to thank the TRC team as well as my co-authors and supervisors for their support and collaboration on this project. I'll be discussing the research project titled Motives for Cannabis Use in Individuals with Clinical Anxiety. I'll specifically review the background information, aims and hypotheses of the study, methods, results, and discussion. I will also include invitations and future directions. So why study motives for cannabis use in those with anxiety and related disorders? Cannabis use is often a concern in this population. Individuals with high anxiety use cannabis at a higher rate and are at higher risk of cannabis use disorder than those with low anxiety. Frequent and infrequent cannabis users are both at higher risk of an anxiety disorder than non-users. However, frequent users are even more likely than infrequent users to have a mood or anxiety disorder, as well as cannabis dependence. Additionally, there is evidence for a positive association between cannabis use and both subclinical anxiety symptoms as well as some clinical anxiety disorders. So overall, there is a fairly well-established link between cannabis use and anxiety. However, there are few studies looking at this in clinical anxiety and related disorder samples. So we conducted a study in 2019 to examine the relationship between cannabis and anxiety in a sample of individuals with likely clinical anxiety, as they were referred to our clinic that specializes in anxiety disorders by healthcare professionals, specifically for anxiety and related concerns. We found that cannabis use was reported at an elevated rate in the sample, with 39% of individuals reporting use in the past 6 months. This is higher than the 22% of Canadians ages 16 and older that reported using cannabis in the past 12 months for non-medical purposes. 22% of cannabis users exceeded the cutoff score on the QDIT-R, which is a screening tool for cannabis use disorder, or CUD. So 22% likely had CUD. In the general population, the 12-month prevalence of CUD is approximately 2 to 4% only. We also found a small but significant correlation between cannabis use severity and level of psychological distress in general. We found similar correlations between cannabis and stress, anxiety, and depression. So why are individuals using at this rate? One of the main models referred to in the literature examining the association between cannabis use and anxiety is the tension reduction model. This model characterizes substance use in general as a means to reduce tension, which is derived from an unsatisfied need. The reduction in tension is rewarding and therefore perpetuates further substance use. Other models of substance use used to explain the relationship between cannabis and anxiety are the motivational model of alcohol use and the mutual maintenance models. The motivational model is similar in that it describes substance use as a method of managing distressing emotions, such as providing a sense of avoidance or escape, so similar to the tension reduction model. However, it also suggests that substances are used to enhance positive emotions. The mutual maintenance model suggests that comorbid anxiety and substance use disorders maintain and exacerbate each other, where anxiety may lead to self-medication with substances and substance use disorders may exacerbate anxiety symptoms. These are broad models to describe the association between cannabis use and anxiety, but they don't give us very specific reasons for use. There are 5 main motives for cannabis use that have been identified in the literature to explain cannabis use in general. Expansion is using to change our thinking. Conformity is using due to peer pressure. Social motives is using for reasons relevant to social situations like parties, confidence, and so on. Enhancement is using for the feeling or for fun. And coping is used to manage distress. Coping motives seem to be the most consistently reported motive for cannabis use in those with subclinical anxiety across studies. Coping motives also fit well into any of the 3 models of substance use previously described. This brings me to the aims and hypotheses of the current study. The aims of the current study were, number 1, to examine the rate of motives for cannabis use in a clinical sample, that is, individuals with anxiety and related disorders, and 2, to compare motives for use between frequent and infrequent users in this population to see if there's a difference. Our hypotheses are based on the previous research in subclinical anxiety samples, as well as the tension reduction model. We predicted that, number 1, coping motives would be endorsed at a higher rate than other motives in both frequent and infrequent cannabis users. Number 2, that frequent cannabis users would endorse coping motives at a higher rate than infrequent users. Participants were 482 adults seeking services for anxiety and related disorders. Of those, 54 were categorized as infrequent users, 90 as frequent users, and 172 as non-users. Infrequent users were those who reported using monthly or less to 2 to 4 times per month on question 1 of the Q.R, which asks about cannabis use frequency. Frequent users were those who reported using 2 to 3 times per week or more. All participants received a diagnostic assessment for anxiety and related disorders, then referred to a group psychological treatment specific to their primary concern at the time. As per the clinic's policy, individuals must have a diagnosis matching the group treatment, whether principal or additional diagnosis, to be referred to a group. However, the diagnostic data was not always available, unfortunately. So to ensure that individuals had clinically significant symptoms, they had to score above an anxiety and related disorder specific measure cutoff score to be included in the study. Additionally, participants completed cannabis measures. They completed the marijuana motives measure, or the MMM, which measures the 5 motives for cannabis use previously described. The Q.R, Cannabis Use Disorder Identification Test Revised, measured symptoms of cannabis use disorder. And for the purpose of this study, the Marijuana History Questionnaire, the MHQ, was used to measure the amount of cannabis use per week and per day in grams. In terms of descriptive statistics, principal diagnoses and additional diagnoses of the sample were primarily anxiety and related disorders, as well as mood disorders. Most participants identified as female, currently had a significant other, completed post-secondary education, and identified as white. When comparing infrequent, frequent, and non-user subgroups, there were no differences on the various demographic variables except for age, where non-users were significantly older than infrequent users. In terms of cannabis use, 30% of the total sample reported using cannabis in the past 6 months, which is quite high. Infrequent users used a mean of 0.23 grams of cannabis per day and 0.85 per week. Frequent cannabis users used a mean of 1.21 grams per day and 6.8 grams per week. And then the mean Q.R score, again, that's the CUD screener, were 3.82 in the infrequent users, which is quite low, especially compared to the 11.61 mean score of frequent users. Only 2% of infrequent users were likely to meet CUD criteria versus 37% of frequent users. Again, this is pretty elevated compared to the general population. In terms of motives for cannabis use, we see that enhancement and coping motives are the most commonly reported compared to other motives. Only expansion and social motives are reported at similar rates, as well as coping and enhancement. When we compare rates of motives reported between infrequent and frequent cannabis users, we see that coping and expansion motives are reported significantly more in frequent than infrequent users. All other motives are reported at similar rates between both cannabis user groups. So what do we make of this? Individuals with anxiety-related disorders use cannabis for several different reasons. So as hypothesized, coping motives were frequently reported in the sample in line with the tension reduction model, where it is likely they're using to manage their anxiety. Future research is needed to examine the specific association between coping motives, anxiety-related disorders, and patterns of cannabis use in this population to explore this more specifically. Coping motives were also more frequently endorsed in frequent users compared to infrequent users. It may be that frequent users experience more distress than infrequent users, and previous studies support a positive relationship between cannabis use and distress. However, it is unclear what the source of distress is. For example, it may be more severe anxiety-related disorder symptoms. It may be more cannabis use disorder and withdrawal symptoms, which includes anxiety as one of the symptoms, or it could be a combination of these things. The mutual maintenance model may be particularly relevant in this population for those who use cannabis use frequently. However, this needs to be researched explicitly. Enhancement motives were also frequently endorsed, which may not necessarily be related to their anxiety and related disorders. Previous research suggests that enhancement motives are common in the general population. This partially supports the motivational model, as individuals with anxiety and related disorders not only use to cope, but also to enhance positive emotions, or such as increasing enjoyment. Future research should specifically compare enhancement motive rates between clinical samples and the general population. Further, expansion motives were more frequently endorsed in frequent users than infrequent users. Previous studies have shown a positive association between cannabis use frequency and expansion motives, as well as indirect links between expansion motives and anxiety. It's unclear why this is the case, but in this population, expansion motives may represent use to think differently about stressors or problem solve. However, this is only speculation. Research is needed to examine specifically why individuals with anxiety-related disorders use cannabis for expansion motives and how this may be associated with elevated rates of cannabis use. The current study has important limitations to be considered. First, unlike alcohol, there are no standardized recommended consumption guidelines to identify a concerning amount of cannabis use. Therefore, defining cannabis user groups is inconsistent across studies. The current study used frequency of cannabis use to define groups, but also reported amount used daily and weekly, so that studies can be compared on definitions of cannabis user groups and consider these definitions in interpreting the findings. Additionally, the sample was ethnically homogeneous and therefore not representative of motives for use across diverse ethnicities. Some studies have shown differences in motives for cannabis use in other ethnic groups. Future studies should closely examine differences in motives endorsed across various ethnic groups, as well as moderating factors such as minority stress, cultural social norms, specifically in those with anxiety-related disorders, to inform inclusive screening and treatment protocols. Finally, although self-report measures used have been previously validated, self-report measures in general run the risk of biased reporting, such as under or over-reporting cannabis use or anxiety symptoms. Thank you for listening to this talk.